This session will cover the pharmacist's approach to dizziness and vertigo. Acute dizziness is among the most common causes for visiting the emergency department. The differential diagnosis of dizziness is challenging for several reasons. One, because dizziness can be a manifestation of conditions that vary from life-threatening disorders to normal basic physiologic responses that are not alarming. Two, because no diagnostic confirmatory tool is available for most disorders causing dizziness. Thus, the diagnosis is largely based on a collection of clinical features obtained with history taking and bedside examinations. Dizziness can occur at any age, but the most common age is around the mid-40s. Dizziness affects at least 20 to 30% of the general population and is more common in women or those with psychiatric disorders like anxiety. Dizziness is not a diagnosis, but a complaint, and the most common reason why the elderly present to a physician. Due to the generality of the term dizziness, in working up a patient with dizziness, they are generally classified into four groups, with vertigo being the most common. The first type, vertigo, involves illusion of movement, also described as a spinning sensation and termed vertigo. The second type is a presyncopal episode, or the feeling of imminent fainting or loss of consciousness. The third type is disequilibrium, or a impaired balance and gait. The fourth type is lightheadedness, which is an indistinct term used to describe symptoms that do not fit into the other categories. Assessment of a patient with complaints of dizziness requires a thorough history and physical examination in order to determine the actual underlying issue. Assessment of characteristics of the dizziness include the onset, duration, number of episodes, questioning for possible triggers, and other signs. If dizziness is not due to vertigo, then further workup is needed and can be started in the A&E. Numerous evaluations can be done based on the patient history and severity of the complaints to help identify the cause. BPPV, or benign paroxysmal positional vertigo, is the most common cause of positional vertigo. However, drugs are generally not useful for this form of vertigo, and physical rehabilitation is the appropriate treatment. In fact, you can see many of the several types of vertigo do not require any medication therapy. However, many still do. As you can see, the diagnosis of dizziness is very complex, and you will not be expected to memorize this table. Social history should be evaluated, as many factors can precipitate or worsen dizziness and vertigo, such as using alcohol, nicotine, or caffeine. Current or prior history of illicit drug use, sexual history, traumatic head injuries, cervical trauma, depression, anxiety, and other conditions like blood pressure alterations, arrhythmias, or dehydration should be noted, since all can manifest as dizziness. Central vertigo occurs in less than 20% of cases and is commonly due to migraines, cerebrovascular disease, or others. Peripheral vertigo occurs more frequently and is primarily due to infection, inflammation, and/or stimulation of various auditory nerves and organs. Typical features of peripheral vertigo include a short or episodic time course, a precipitating factor, sweating, pallor, nausea, or vomiting. It may also be associated with tinnitus, hearing loss, auditory fullness, or facial nerve weakness. In central vertigo, autonomic symptoms are less severe and hearing loss is uncommon. It has a gradual onset and is associated with neurologic symptoms such as visual changes, weakness, numbness, dysarthria, ataxia, and loss of consciousness. A comprehensive review of the patient's medication history should be performed to determine whether therapy must be altered. The administration of certain drugs like amiodarone, cisplatin, furosemide, gentamicin, and tobramycin may result in direct ototoxicity and should be discontinued in patients experiencing vertigo. Psychotropic agents, antihypertensives, anti-inflammatory agents, and muscle relaxants are also reported to cause lightheadedness and disequilibrium in patients. Several drugs can cause orthostatic hypotension, which may appear as dizziness. Treatment has two components: treating the underlying cause, such as one of the disease states, and also symptomatic treatment, usually via vestibular suppression. Anemia, iron deficiency, malignancy, vitamin deficiency, and chronic blood loss may result in insufficient blood flow to the brain and manifest as lightheadedness. Patients with thyroid dysfunction or hypoglycemia may also present to the A&E with dizziness. Pregnancy or menstruation may cause lightheadedness due to acute changes in hormone levels. Patients with extremely severe orthostatic hypotension can be treated with midodrine or fludrocortisone to increase blood pressure. However, blood pressure monitoring is necessary to prevent any hypertensive complication. Midodrine should not be taken within 4 hours of bedtime or when lying down, as it could cause supine hypertension. Other common side effects include urinary frequency, urinary retention, and skin rash. Fludrocortisone, or Florinef, is a mineralocorticoid that increases sodium and water retention. Thus, it is important to monitor potassium levels and for heart failure symptoms. Other common side effects include edema, hyperglycemia, and muscle weakness. Psychogenic dizziness can occur in patients with chronic anxiety. Panic attacks are described as sudden, intense fear or discomfort and are often associated with dizziness, nausea, shortness of breath, chest tightness, paresthesias, and perspiration. Benzodiazepines can be used for short-term treatment of anxiety and dizziness. There are three main categories of vestibular suppressants: the anticholinergics or antihistamines, benzodiazepines, and antiemetics. Antihistamines, such as diphenhydramine or beta-histine, have anticholinergic effects that provide relief. Benzodiazepines are effective for vertigo, but there, of course, is the concern that they may be habit-forming. For acute cases of severe vertigo, promethazine or metoclopramide can be used. Physical therapy and vestibular exercises of various head and body position movements are also highly recommended. Pharmacists play a role in identifying causative medicines, referring to a physician for more severe causes if they present to you in a community pharmacy setting, and also to provide counseling on treatments provided and other non-pharmacologic measures that should be employed. These are the references. Thank you for watching.